first of all, I would Dr.
Sir,
Satyan.
sir, just a minute. Let me introduce you first.
Sorry.
Okay, so we have already late. Anyhow, sir, welcome to this session. So, Dr. Nikunj Rout is a professor and head of Department of Nephrology at KIMS, Bhubaneswar, where he leads clinical services. He is the HOD of that department in kidney care, including nephrology, dialysis, and renal transplantation. He holds advanced qualification in internal medicine and nephrology like MD and DM, and has expertise in managing acute and chronic kidney diseases, hemodialysis, and kidney transplant program. And Dr. Rout has contributed to both patient care and academic research with several publications in areas such as kidney injury and chronic renal failure, and is active in scientific discussion and national conferences. Currently, I am also working with Dr. Nikunj in a project of ICMR. Thank you, sir. Now session is yours, sir.
Thanks for the kind words, sir. So today we all have gathered here to look into how the artificial intelligence is getting integrated with the nephrology services. Usually, I had been given a topic key, sir, just start an initiative so that we can get more involved in machine learning project. So my topic would be hospitalization predictive models in CKD in dialysis patient. Let's begin. So once again. So what is artificial intelligence? I will not go into detail. I will only touch into the definition and all things. It is a branch of science that enables the machine to mimic basic human cognitive behavior, making it possible to think, learn, reason, and act based on the prior experiences. So it has subsets that you can see. Machine learning, robotics, and natural language processing, what is known as NPL. So if we look into the machine learning part, it is the most common form of AI currently used in the medical sciences, defined as the type of program algorithm that learns from the prior experiences and continues to improve performing based on the learning. So I would not go into the detailed subsets that you all are much more learned than me. It is supervised, semi-supervised, unsupervised, enable, what is known as ensemble learning and reinforcement learning. So how it is integrated with the nephrology practices, that is what we are looking into. You can see that much of the work has been done in acute kidney injury, looking into the factor for the early prediction of the acute kidney injury in various settings. There has been studies done in imaging, in detection of the malignant lesions, and measuring the total kidney volume in autosomal dominant polycystic kidney disease, in which there are large cysts and the kidney grows into huge cystic form, and that lead to deterioration in the renal function. Work has been done in kidney transplantation, which predict the long-term survival. Work has been done in chronic kidney disease, prediction models for progression of the CKD. Work has been done in the kidney pathology. It is the histopathology after the renal biopsy, detection of the various renal pathology from the biopsy. And there has been work ongoing on the dialysis, optimize the dialysis therapy and reduce the hospitalization rate. So this is one of the papers that has been published in 2025. I will just give an example how these studies are being done. It is an artificial intelligence model to predict the mortality among the hemodialysis patient. It is a retrospective validated cohort study. It is a Chinese cohort and done by Zhong Peng and the group. In the introduction, they have given that hemodialysis is the most common renal replacement therapy globally. However, the mortality rates in hemodialysis patients are quite high, 3.8 to 9 times in China. And of course, this is likely to be in India also. And accurately identifying the mortality risk is crucial for the timely management and tailored intervention, especially when considering kidney transplant surgery. Traditional predictive models are based only on the Cox regression analysis, which have a very low predictive performance. AUC is around 0.8, making them insufficient for the clinical use. So this study was objectively designed and aimed to establish and validate AI model to accurately predict 1 year, 4 year, and 7 year mortality among the hemodialysis patients. So this cohort involved nearly 559 patients from a large tertiary care hospital, split into 80% training and 20% internal validation. And external validation, 82 patients were taken from another tertiary care hospital, confirmed the model robust performance. So this is the what we say. This is the ones. The experimental design consisting three main components: the data collection, randomization, and modeling and validation. And the study employed various techniques for modeling, including the logistic regression model, as well as machine learning model and neural network and decision tree, extreme gradient or EXGMB, and support vector machine learning. And these all four learning technique, machine learning techniques has been utilized in this. So this what this study identified. Actually, it identified there were the multivariate Cox regression analysis identified 5 key factors which were independently associated with the mortality of the dialysis patient. Age was one of the factor which was positively correlated. Increasing age was significantly associated with mortality. Patient with ischemic heart diseases had more risk of mortality. Ejection fraction of the patient, that is the heart pumping or it is a predictor of how much the heart pumps, ejection fraction. This is also, if it is less, then the mortality is higher. Serum albumin is another parameter that is shows nutrition and inflammation. If low albumin level led to negatively related with survival, and neutrophils, which are sensitive to infection and inflammation. So this model comparison shows these 5 techniques or the machine learning, and you can clearly see the extreme gradient boosting machine model consistently demonstrated superior performance as compared to the others in predicting the mortality across the time point in 1 year mortality, 4 year mortality, and 7 year mortality. There are this EXGMB model had 1 year mortality. It has excellent short-term survival predictive power with 0.79, and followed by 4 year it was 0.933. It has a robust performance, and 0.935 long-term predictive capability. And external validations confirmed the model generalizability with a AUC of 0.892. So with this, they developed a clinical online AI application through which in which you can put the variables, parameters, and they can predict the 1 year, 4 year, and 7 year mortality risk, and they can risk stratify, and they can suggest what need to be done for this. So guiding the clinical decisions was very important. If a patient is in the high risk group, then for this patient, you should not advise the renal transplantation. It will offer very little benefit. And low risk patients who are younger and have extended survival, kidney transplantation surgery offers a favorable outcome. So these were helpful in making decisions. And intervention strategy based on predictors can also be done. These studies highlight the importance of managing the 5 key risk factors to improve the renal outcomes. Like ischemic heart disease, you need to manage the ultrafiltration, means dragging the water during the dialysis period. You have to counsel the patient about the diet, not to take much of fluid, and regular cardiac Doppler need to be done. In albumin nutrition part, you need to get consultation from the dietitian to improve the nutrition of the patient, and the modality of the dialysis need to be improved. Neutrophils are elevated, then you need to take care of the infection and inflammation. And for the age also, in elderly and patient with more comorbidities, you need to have radical management approach. So next I will discuss what is our problem statement and the things that we can do in our setup. First thing, we can AI integrate clinical bioimpedance data, BP trends, and lab markers to personalize the fluid removal in dialysis patient? the that is the ultrafiltration profiling, how much fluid need to be removed and at what pace to reduce the hospitalization rate. That can be one of the question. Now, what is the concept of dry weight in a dialysis patient? Means a person on dialysis doesn't produce much of urine, so he gains weight on regular. If for day one he had been dialyzed, he will reduce the weight. If you had dragged out suppose 3 liters of fluid from his body, from the day 2 onwards, he will start gaining weight. That you can see, this is the maximum weight. After dialysis, he had lost weight, then he starts gaining. In 2 to 3 days time, he again gains weight. So this is the minimum weight, which is the target weight in which is the ideal body weight at the end of the treatment. After all excess fluid has been removed, is known as dry weight. It is the lowest weight that the patient can safely tolerate without developing symptoms, that is the low blood pressure or dehydration. This is the lowest weight below which if you go or drag out fluid from a dialysis patient, he will develop hypotension. So this weight need to be determined in each dialysis patient. Suppose I am 80 kg weight, I had gained weight due to fluid accumulation. So my dry weight need to be determined and we need to drag out fluid. So this, how much fluid to be taken out at how much time period, that is the main thing in these patients. So why dry weight adjustment is difficult? Because it is dynamic and not static. Conventional assessment were only relied on how much the patient has intradialytic weight gain, what was the BP. If patient is having hypertension, then he is accumulating more fluid. If he has edema, swelling over the body, or his lungs have fluids, then crepitations, that is a sign of fluid overload. Patient symptoms like cramps and dizziness. But there are certain limitation in this method. Each time a doctor has to be involved in assessment of the driver, and it was subjective. Poor sensitivity to the subclinical hypovolemia. If you cannot detect hypovolemia and we had advised to drag fluid, patient will develop hypertension or sudden decline in BP. So late detection can lead to intradialytic hypertension and chronic volume overload state. If we are not able to detect, then patient will lead up in volume overload or shortness of breath. So how the AI can assist in driver adjustment is through by integration of the multiple variables. AI models can integrate pre and post dialysis BP trends, bioimpedance spectroscopic data, extracellular water as intracellular water ratio can be calculated from this machine. USG machine can detect the vena cava, our vein, the main blood vessel or vein diameter, how much it is full, how much water to be taken out. Ultrafiltration history can be integrated. Symptoms of cramp and dizziness, if it is happening during the dialysis, that can be noted. NT-proBNP is a marker of fluid overload that can be taken into picture. And these all dialysis machine data can give a real-time data. So the AI can detect the pattern that are not visible to the human judgment. So second thing, it can be used for predicting true euvolumic dry weight. AI processing can lead to time series machine learning models, pattern recognition across multiple sessions, and detection of latent fluid overload or volume depletion. And the output that we can get is probability of fluid overload or hypovolemia. It can suggest a dry weight change, suppose 0.3 kg that have changed, or risk score for intradialytic hypotension target can be determined. So third thing that can be useful is the prevention of intradialytic hypotension. AI can predict the intradialytic hypotension, that is 30 to 60 minutes before its onset. If our ultrafiltration driving is rapid, if our red blood cell volume slope is steep as we are taking out fluid from the blood would get concentrated. That will give the RBV volume slope. BP variability, BP can fluctuate. Past history of hypertension can also be taken into account. So it can predict the intradialytic hypertension tendency. So the actionable input can reduce ultrafiltrate, modify target of dry weight, and extend dialysis time so that the rate of ultrafiltration is not higher. These well can be output which can prevent the outcome. So the clinical benefit can be fewer intradialytic hypertensive episode, reduced myocardial stunning, improved BP control, lower hospitalization due to heart failure, and objective reproducible decisions. Second question that we can have for AI is artificial intelligence hospital-based predictive model in chronic kidney disease and dialysis patient for risk stratification to clinical decision support. In this, we can take background of the CKD and dialysis patient who have higher and recurrent hospitalization rate. Hospitalization are driven mainly by few things that are volume overload that I have discussed. There can be episode of infection, cardiovascular events like myocardial heart attack, arrhythmias, electrolyte imbalance, or dialysis related complications. And conventional scores are static, have use limited variables and perform poorly at individual level. So rationale of using AI is CKD and dialysis generate a large longitudinal data set, and AI can integrate dynamic variables and detect nonlinear interactions and provide real-time prediction model. So early prediction, preventive intervention can be done, and reduce morbidity and reduce cost can be brought out. So common predictors that can be used are usually demographic data, comorbidities like diabetes, hypertension, previous history of any cerebrovascular disease. Lab variables can be used, hemoglobin, albumin, phosphate, and there are different lab parameters. Dialysis parameters can be used, prior hospitalization history and BP variabilities. These can be predictors. And hospitalization burden of usually CKD is 2 to 3 times they are more likely to get hospitalized. And hemodialysis patient have an annual risk of 1.5 to 2 hospitalization per patient per year. So the major causes I have discussed is fluid overload and infection. So traditional predictive model usually use the logistic regression and have limited variables and have poor generalizability. AI can just pick up the variables that are very closely associated with that we are seeing. So the primary aim of the study that it can have to evaluate the role of AI predictive models in forecasting the hospitalization in CKD in hemodialysis patient. Primary objective would to develop a AI model to predict 30 days and 90 days hospitalization risk, and to compare AI model with traditional statistical model, and to identify key predictor contributing to the hospitalization. So the secondary objective, like to assess the model performance across CKD stage, incident and prevalent dialysis patient can also be done, and to explore clinical applicability of the decision tool for support. These are the ideas that we can imply in dialysis patient. So this main purpose is to give out a what we say algorithm in which AI can be used in dialysis patient for a predictive risk model assessment. So this is a methodology. I will not go into detail. This can be done. How the study design can be, it can be retrospective, prospective, both. Population can be of CKD stage 3 to stage 5 and dialysis patient. Exclusion criteria are only those patients on acute kidney injury. And data sources can be EMRs, dialysis machine data, and laboratory database. So variables can be used that I had shown. Demographic, clinical, lab, and dialysis specific. AI models that we can use are these, and outcome can be unplanned hospitalization within 30 to 19 days. And these are the AI model, precision recall. So what are the key predictors that may be identified through this study is the rapid intradialytic weight gain. Is this associated with hospitalization, low albumin, frequent intradialytic hypotension, high CRP levels, recent dry weight change, or other variables that can be seen. So thank you. I think that's all from my presentation. I think
Thank you,
now.
sir. So one or two questions we can take as the students, other students have joined for the cultural. Dr. Ponapa, PG Ponapa, just ask one question, sir. Ponapa is one of the assistant surgeon working in Mysore, but he's very much inclined towards the AI. That's why he's doing his MCA in AI and data science. Yes, Ponapa, any question from your side? Hello. You can unmute yourself, Ponapa. Now you can unmute yourself.
Yes, sir. Good afternoon. I didn't know that artificial intelligence can be used in this field also. Yeah, I think these dialysis patients have their own set of problems and which you people are trying. Hello? Hello?
Yes, you are audible, sir.
Yeah. I think this is another eye-opener for me because it can be applied in that field also.
Dr. Panappa?
Yeah. I'm able to hear you. So I think a lot of sufferings can be minimized by using AI in nephrology field also, I guess. This is new to me. I was thinking mostly in surgical field, but now nephrology also adds on to the domain.
Sir, he is audible to us. I think some problem from your
Sir, I
side.
think Dr. Punappa is mute.
And now he is mute, but previously.
Hello.
Hello.
Hello, yeah. I just hello, you able to hear?
Yes, yes.
Yeah. I just trying to confess. I never ever thought that this nephrology can also be applied, especially when dialysis and all those things. It was an interesting eye opener for me because the fluid balancing and when to do, when not to do, is a very. Since we are all thinking of evidence-based
Sir,
medicine,
you two are
I
not
think.
audible.
Oh, okay. Well,
Actually,
that's it, I
Ponama is
guess.
audible, sir. From your side, some problem is there, I think.
All right. Right, sir. That's all from my side. Thank you.
Okay, sir. I will take the question and I will discuss it with later. Nikunj,
Sir,
sir.
I am not able to.
You have some problem in your side. Sir, thank you, sir. Phone call. Okay, thank you, sir.